Okay, go live. Wait for it. Wait for it. Wait to make sure it's going. All right, you're live. Minimize out. Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation. Welcome to our March 2021 VBF Facebook Live. I'm coming live from New York, and today's guest is Dr. Giacomo Colletti, the VBF Europe Director and the VBF Italy Director, live from Milan, Italy. Hello, Dr. Coletti.
Hi, Linda. Hi, everybody.
How are things in Italy going right now with COVID?
Well, actually, things are pretty bad right now. We're sadly very close to a new lockdown, national lockdown.
Not good.
Yeah, this is what they say because there is a huge rise in number of cases, and so I guess they have to do it. It's pretty bad, yeah. Things are pretty bad right now.
Let me just
sadly very close to
take the volume down. Corinne says, hi, Dr. Coletti. Corinne here from Seattle waiting for her dentist appointment.
Oh, I see. Good luck.
Caitlin Gray is watching. Deborah Codrington is watching. So we are live, everyone, and we can take your questions. Dr. Coletti was just making us aware of the situation in Italy, which is important because he and I are trying to coordinate a free 2021 laser clinic in Italy. We'll be announcing it as soon as the borders open, which I did read the borders in Europe are open. So like people from Greece could go to Italy, I thought, but the real question is coming from the US to go to Italy is supposedly not happening. So I don't know, we were hoping to do the free laser clinic in June, but now it might be July or August, correct?
Well, see, Linda, they say that by the end of the summer, they should be able to have everybody here vaccinated. So I suppose that we should see a fall in the number of cases much earlier than that. And this should theoretically allow people to come here, yeah, by June, I would say.
Okay, so maybe we will be okay with the end of June, you know, because we're trying to coordinate a couple free European clinics. But I guess the key is we have to play everything by ear and hope and pray. Fortunately for us, our super clinic, the VBF 2021 super clinic, will be in New York City on Saturday, October 12th at Dr. Geronimus's office. And I will be assisting Dr. Coletti as he does a free ultrasound clinic on Friday. We'll also be having a free dental clinic on Friday. We're finding out right now if that's going to be at the NYU School of Dentistry. But we will soon be putting out an announcement and accepting registrations for the super clinic. Everyone attending who needs a laser will get free laser. Everyone who needs a dental exam related to a vascular birthmark, and everyone who wants to have a clinical diagnosis will be seen. So we're excited about that.
I have to tell everybody that they don't want to miss the VBF Super Clinic. It's an awesome event, awesome for everybody, for doctors, for patients, for everybody.
We're expecting about 200 patients will be coming because so many people have missed going to their own appointments or clinics, especially because for some reason, vascular anomalies is on the bottom of the food chain with, you know, hospitals.
Actually, you have published that in a recent paper, which was published in an international journal. So you published that, yeah.
Right. Oh, Corinne corrected me. Thank you, Corinne. Our conferences, I got mixed up because of this year. We had December 12th. It's October 8th and 9th. Thank you for that correction. So we are taking questions. And just so you know, we're very excited that Dr. Coletti has been and is currently doing, and he has been for months, laser treatments in Milan on Fridays. And if insurance doesn't work, he has a very agreeable flat fee, a VBF flat fee. He can treat every 3 to 4 weeks, you know, with seeing the child or adult back, correct? I'm assuming what kind of anesthesia do you offer? The nerve block and topical?
Yeah, we do both there where I do my laser treatment. It depends on the extent of the area to be treated and on the age of the patient, because adults with very small port wine stains or other vascular anomalies, um, if those anomalies are very tiny, very small areas, then usually a numbing cream is enough. But if you have to treat larger areas in the face or in the body, then we do a nerve block, yeah, which is something not so painful. It's just a half a second injection, and then the whole area is anesthetized, because if you know how to inject the right nerve, just one injection is enough.
And what about for under age 12 months?
Under age 12 months, we don't do anything, because what is known in the literature is that local anesthetics can be hazardous. But this depends again on the many other factors. So sometimes we do some local numbing on very young babies too.
Well, I just want to clarify, when I said under 12 months, you said we don't do anything, meaning you don't give anesthesia, you treat them, but you just don't give.
Sorry.
Yeah.
Sure.
So you have a question from Poppy Guy. Poppy says, my baby has a blue rubber bleb nevus and it bleeds regularly from the external ones. Is that dangerous?
No, it is not usually dangerous, because blue rubber bleb nevus, the external ones, are very easy to manage with just local compression or some coagulative drugs which you can apply there. Blue rubber bleb nevus syndrome is more an issue when it does bleed internally in the intestine, in the bowel. So don't worry about the external ones. Do worry about the internal ones.
The ones in the intestines where
Right.
they have the bleeding. Yeah, I've read about that myself. That's almost one of the ways of diagnosing it when it's confused with venous or some other kind of staining, is you look for that GI involvement, correct?
Yeah, yeah, that's true.
Okay, so we have quite a few people that are on and we're taking your questions. This is a 60-minute session. Oh, we have one. Katerina Mahalovic, greetings to everyone from Serbia. We have heard of an experimental drug for complex AVMs. My daughter has them on her face. Can you tell us something about that? We expect the last round of interventions with Dr. Tombrese as soon as the borders open, but I have to ask this just in case. She's about an experimental drugs for complex AVMs, and her child is young, baby.
Yeah, there is more than one. More than one drug is being experimented for incurable AVMs. Because one thing that has to be clarified is that before thinking of doing anything on an AVM, you have to stage it. So if an AVM is curable, that makes no sense to use drugs if an AVM is curable. If an AVM is no more curable, then you have to know what you want to achieve with the treatment, and if there is a need to treat that AVM. So with this, I mean, you can read in the literature, Dr. Linda and I, we have published a paper which is called SECG staging system. And this helps colleagues and patients to understand how, what stage your or their AVM is in, so you know what is the aim of the treatment, meaning you do want to cure that AVM, so you want to be radical with your treatment, or you want to do simple palliation. So in that case, if you have an incurable AVM, which is symptomatic, then yes, that there is a role for medications. We ourselves are trying some. The most promising ones are lenalidomide and trametinib. Those drugs are used to interfere with angiogenesis. Some of you might be aware of the fact that thalidomide was used during the 60s, 50s, and 60s as an anti-vomiting drug for pregnant women. And this caused disastrous effects because the babies were born with very short upper limb, reason being, and this was called phocomelia, which is translated as seal arms. Reason being that thalidomide and its equivalent lenalidomide, it's an anti-angiogenic drug, very powerful to treat AVMs, incurable ones, or I should say to manage symptoms and so on. So yeah, there are a lot of drugs that are being experimented right now for those.
But right now, for her small age child, there's really no protocol for a small.
No, there is no protocol, no.
Right.
But I am happy to discuss this with you if you want to write directed to me, so maybe I can help you. I don't know.
Yeah, you will remember the case. You did see it. It was one of the ones I shared through our little small international group. So, but she can send it to you. Dr. Coletti's email is giacomo.coletti@gmail.com. So Courtney Lay says her son will be 4 months old on the 14th. We are on a long waiting list for laser treatments and have never gotten one done. His port wine stain is on the left side of his face. Is there a way to know if it will raise up or not?
Well, I'm not sure I understand what you mean raise, but
get thicker and develop lips.
I suppose that.
Yeah.
So untreated port wine stain sooner or later will become hypertrophic. When, we don't know actually, but what we do know is that early laser treatment can prevent some of that cobblestoning that otherwise happens in port wine stains. May I suggest you to seek treatment, because as the Dr. Geronimos and Dr. Nelson teach us, you have to follow the rule of done by one. So the window of opportunity to treat babies with port wine stains is before the age of 1. Not that you cannot achieve anything after that, but the best results are achieved if you do everything that you could before the age of 1. So being your daughter, if I remember well, 4 months old, then this is about time to start treatment.
Well, I mean, it's her son, but the thing is, she's on a waiting list, and she's probably, she can text back from the UK, and it's just, you know, this is why we're so happy you do your laser clinic every Friday in Milan, and once the borders open, it's a very affordable alternative to our families in Europe because you are accessible, and the wait is, some people have to wait until next year to start. So I've told everybody during COVID, there is no done by one. I mean, just because it's almost impossible to achieve that when you can't even get a treatment. And, but the good news is the cobbling and the thickening isn't going to show up until at least adolescence or much later in life. And her son's only 4 months old, so she's not losing anything. She's just getting a lot of anxiousness And like, we're going to be doing free lasers in October in New York. As soon as we get a time, we'll set one up for in Milan. There's going to be another free laser clinic in Europe that will happen right around that time. We have several free laser clinics that are going to be in the US, one in Texas.
I suspect she's from the UK, you said.
I think so.
Yeah, so if this is true, then she might be able to contact me and come here for treatment.
Right, right. So the next question comes from Laura Latimer. Hi to us, you and I, from Nova Scotia, Canada. Is there anything you would suggest to improve scarring after a hemangioma completely ulcerates on an infant's face? We are currently on propranolol and doing wound care. Is laser something you would suggest?
Okay, so I would answer it depends. It depends on where this scarring is located. It depends on the size of the scar. It depends on when the scar happened. And I'm saying so because, yes, the laser might help to make the healing faster than it would by itself, but it won't necessarily help with the scar, sadly. We now know we are starting to think that propranolol might not be a solution to prevent ulceration and or scarring. So I would say that if the area is particularly relevant for aesthetics, then at one point or another, there might be a role for surgery in correcting that.
What about the Fraxel laser, Dr. Coletti?
Depends. It
I
depends.
know. So the real thing is you need to see a picture, and
Right.
from the picture you can advise her. And we've posted your email. You're also at birthmark.org/Coletti or directly at giacomo.coletti@gmail.com. We have a question from Holly Antrop. Her 3-year-old son was recently had an embolization of a complex nasal malformation consisting of a small AVM or hemangioma combined with a high flow arteriovenous fistula draining into a partially thrombosed varix. My question is, what is the likelihood of us having to redo the procedure, and should we expect disfiguration of his nose? So this is very interesting, isn't it? Because she's
That
actually—
is not an AVM.
It is all?
It is not an AVM.
Okay.
I
So
can promise that.
yeah. So are you thinking it's venous?
No, that's a congenital hemangioma. I'm pretty sure.
Yeah.
I'm saying this because I don't know why this is not so well known, but congenital hemangiomas always have vascular patterns of arteriovenous shunting. So in a child 3 years old, say tumor, so they don't know if it's a hemangioma or an AVM. If it's a hemangioma or say a congenital hemangioma, there is a mass. If it's an AVM, there is no mass. So it's pretty, not always, but usually easy to make a differential diagnosis. You cannot make a differential diagnosis just by saying there is a high flow draining into this or that vein, because this is common to AVMs and congenital hemangiomas. Also, in all of the cases that I saw in my career of non-involutive congenital hemangiomas, I was able, you were with me, Linda, one of those times, I was able to show the patient and the doctor who was with me the vascular architecture of a niche, which is exactly the same of an AVM.
So this is a good example of misdiagnosis, and the can result in mishandling. So Holly, this is a very good example of you needing to send Dr. Coletti the baby's pictures. A history of what was there at birth is critical, and when it appeared and how it's changed, which could change the whole course of the treatment. So it's important for you, Holly, to get that information to Dr. Coletti. Again, this is a service that he offers through VBF for all of our families. He'll look at what you send him and give you an opinion, and it's worth its weight in gold to get an accurate opinion. Katerina Mahalovic says her daughter is 22 years old with almost 25 interventions. She also has diabetes. I'm not remembering that case. I guess she must have written to us.
AVM.
Oh, that's AVM?
Yeah.
Okay. That's a lot. And that's another thing. That's why we're promoting worldwide the use of the SECG staging system to really making us rethink when is treatment. It's more like pushing treatment to the side and thinking more of leaving or managing or riding it out,
Yeah, what I think, and I do, because we have discussed this so many times, I believe that AVMs, just like everything, every disease of medicine, has to be approached in a very rational way. So you don't just say, there's an AVM, I do something. The thing that I know how to do better. If I'm a surgeon, I do surgery. If I'm an interventional radiologist, I do embolize it. No, this is not the way to approach them. The way to approach them is to say, what's the size of the AVM? Will I cause some disfigurement or functional impairment if I do treat them? Is it curable? It is not anymore curable, healable, I should say. When you know this, you go on and you say, is this AVM symptomatic or not? Say you have a very small AVM in the face, removing which will not cause any disfigurement or functional impairment. Then go on, remove it in a radical way, just like you would do on a tumor. It is much different if this is an extended AVM or an AVM in such a region, such as the lid, the eyelid, where removing it would cause significant disfigurement or functional impairment. Then you should think, and this is stage S3 according to our staging system, then you should say, is this AVM symptomatic? Meaning, is it bleeding? Is it becoming infected? Is it painful? And so on. If it's not, then consider the G letter, which means, is it stable or is it growing? If an AVM, an S3, again, something that approaching would cause disfigurement or functional impairment, is not symptomatic and it's stable over time, leave it alone. Don't treat it. Follow the patient every 4 to 6 months. If things change, then do treat it. If they don't, leave it alone.
Agreed. Oh, Poppy Guy just gave us some good information. She said in the UK, the Great Ormond Street Hospital is gave her baby quick treatment. So you can, those of you in the UK can try there. I've been hearing that there's quite a long wait for laser, but they may have opened up now. So please, by all means, try that. Courtney Lay said you indicated that there would be free laser in the US. Send or post it. We are getting ready to post that. I posted a teaser a few weeks ago saying we were going to have 5 free laser sessions in the next 12 months. I'm working on one right now in the Philippines, which will be bring a lot of hope to a lot of people in the Philippines. So I'm waiting to post all of them in the next few weeks when I find out if we will have the free laser in the Philippines. If not, I'll post the 4 of them. But I can tell you December 4th is in Texas and October 9th is in New York City. And those are just 2. So I can tell you those. So there you go, Courtney. Now you have a choice. You can even go to both. You can come for the October 9th one in New York City and then go December 4th to Texas. Hi, Judy. Hi, everybody. Okay, let's see. Hi, Ivana, Nikki, Selena. I'm seeing a lot of people are jumping on. Ania Banazek says, hi, Dr. Lena. Buonasera, Dr. Coletti. She said, I would like to ask if you perform sclerosing treatments with Bleo in Milan. My son is 9. He has had many he's had surgeries with in Berlin 9 years ago with Weiner and Meyer. Now, it was very difficult to find help in Italy. They're in Italy. He had treatments at Gaslini, but no result. So it was a blessing for us for them to go to Berlin. But she said it would be awesome to have a trusted doctor in Italy. They live in Cuneo, Cuneo?
Cuneo, yeah.
Cuneo, so Milan is really close. So
yes, it's very close.
Take it away. Do you do?
Oh, yeah. Just to answer the question, yeah, definitely I do use Bleo to sclerose venous malformations, and I use it quite frequently. But for more difficult ones or less responsive to traditional approaches, then I use a secret formula of sclerosants together to obtain what I say in my hands are better results. Linda, you saw quite a few.
Mm-hmm.
So yeah, contact me please via
Yes.
email and I'll be glad to answer to you.
Yes, Ania, Giacomo.Colletti@gmail.com, and I will be there this summer for our free laser clinic. We'll possibly be doing a diagnostic clinic. Dr. Stuart Nelson will be joining us, so maybe I will see you. Gina Sulfan writes, she's a 47-year-old and has a small 1.5-inch port wine stain on her cheek, her face. Okay, let me just, I lost this, on her here. It has always been flat with no changes until the last 2 years. So possibly she's in menopause. I'm noticing mild changes, textural changes. I don't mind its appearance or want to remove it, but should I be concerned about these changes in the skin texture? Would you recommend treatment now to stop advancing of the skin texture?
I'm not sure I understood correctly because you said 1.5 millimeters.
No. So she has a 1.5 inch, say the size of a quarter, 25-cent piece.
Oh.
It's on her cheek, but she's noticing that it's being the skin and textures because she's 47. So it's probably, being hormone driven, maybe.
I would say I would treat it. Reason being that PDL laser can prevent those changes. So it can prevent the formation of nodules, cobblestones we call them, which are usually they do bleed and they cause some discomfort to the patient. So yes, I would do laser, PDL laser. When a cobblestone is already there, then you can do surgery or ND-GAG laser. So again, send me a picture and I will tell you what I would do.
Great. So Ivana writes directly to you. Ivana Goran Iljazev. Good evening, Dr. Coletti and Dr. Linda. We are the parents of, I guess they were scheduled, parents of Leon. We were supposed to bring our son to Dr. Coletti in early 2020, but then we were told Leon's hemangioma was not a hemangioma, but a dermoid cyst and has been operated last May. After a month, it started growing again, and the histological results have confirmed once again that it was a neoformation fibrosis, some kind of fibrosing lesion.
Yeah, put me in contact with the pathologist.
Okay, she's saying, yeah, Yeah, she's reading all this positive for CD31, CD32. Yeah, so why don't you get the,
31 positive, then it's vascular.
yeah, so Ivana, email Dr. Coletti at giacomo.coletti@gmail.com. Send him your information on the pathologist and send him a copy of the report. And then he can give you, because he's saying it does sound like it's possibly maybe been misdiagnosed and is a vascular
And
lesion.
pictures also.
Yeah.
Clinical pictures.
Correct. So Ivana also says, sorry for some Italian phrases, but I didn't know how to write them in English. That's fine. I don't know a lot of phrases either. Welcome to my world. So Jennifer Lynn, for the free laser in the US or Europe, it's we don't turn people away. So let's just put it that way. If I'm in Italy and doing the free laser clinic with Dr. Coletti and there's more patients, I won't even let him go have dinner. He has to stay and treat the patients first. And all my doctors know this. They're not allowed to leave until, and you know this, Dr. Coletti, you've been on the I-teams and you know every patient.
You're always the boss.
Yep, I don't close the door on anyone. So don't worry about it, Jennifer, when you see it. If you want to come to New York or Texas or other locations, then sign up and you'll get the free laser. Hi, Michelle. Toby says hi, everyone, to Toby from Thunder Bay, Ontario, Canada. Sorry, we didn't come there last year. We were supposed to for the ISFA conference. That didn't happen. Nike Oliajo says, hi, this is Nike from Nigeria. Hello from Nigeria, stay safe. Selena's saying her daughter is 8 months old and has been on propranolol for 4 months to reduce a deep and superficial nasal hemangioma. The swelling has reduced significantly, but the nose is not symmetrical as it was at birth. The right side is lower than the left. Is it possible it will resolve on its own, or will surgery be required, and at what age should this be done? Will it leave scars?
Okay, so when we did not have propranolol, nasal tip hemangiomas would always produce a condition known as Cyrano nose, after the name of Cyrano de Bergerac. Now, I have to say, most of the babies that I see with nasal tip hemangiomas do not require any surgery. They do heal by themselves. Although, what you do describe to me, so one nostril being lower than the other, might imply the fact that there is still some deep-seated hemangioma pushing the nostril. So it might be the case to do surgery on your baby. I would say let's wait some more, 3 to 4 months, maybe more, and see what propranolol does, and then we'll decide together. Then you will send me the picture and we'll discuss the treatment options. As a first thought, I would say your baby will not need any surgery, but we'll see.
And remember, as I said to everyone, because a lot of you have come on since, with the VBF will be having a super clinic in December rather than it will be in person, I'm sorry, in October. Like last year, the talks will all be uploaded, but we're gonna have 7 teams of doctors seeing all the patients, free laser and free dental, and Dr. Coletti will be with us in New York in October. And we will be doing, he and I will be doing together a free ultrasound clinic. Kristen Peterson, Sorbonne says, is it safe to take tranexamic acid?
Tranexamic.
Okay, how do you say it?
Tranexamic.
Okay, tranexamic acid when you have a VM.
Well, tranexamic acid can be administered in many different ways. So you can use it topically, which is absolutely recommended. You can ingest it, or you can administer it IV. So small doses, just stat of tranexamic acid will not do any harm, but don't use it on a regular basis because that can cause thrombosis.
Mm.
Okay, so
I think that's
don't do that.
probably what she wanted to know.
You
Yeah.
don't have to do that.
Okay. Good to know. Ava Pyle said, hi, Dr. Coletti and Dr. Linda.
Hi, Eva.
And Michelle Nayan is saying, hi, Dr. Linda and Dr. Coletti. Polly from the UK, my son has had pulse dye laser on his port wine stain for 14 years, but it keeps coming back. Anything new to try?
There is something new, but I cannot talk about that.
Stay tuned.
Stay tuned.
And maybe come to our free laser clinic in Milan, and then
Maybe.
you can find out, get free laser, because you and I talk about these that are getting treated and then they just completely come back. So anyways, Toby has a
Sorry,
question.
Linda, we have, no, I should be more specific on this.
Okay.
We will be starting 2 specific research projects for non-responder or relapsing port wine stains, 2 specific ways of address that kind of port wine stains. So you might be interested in trying one of the 2 ways that we want to try. There is a rational and a scientific basis. Obviously, we're not trying what comes into our mind from one night to the morning. Yeah. So just stay focused. We might have something for you.
So Toby Perna says, well, we don't know. I doubt ISFA will be coming back to Canada, because I think they're already selecting the next location. I don't know if
No,
you know.
it will be in Canada again.
Oh, it will be. So it's next year, right? So we will be in, is it, or Toronto, right? Or
Okay.
Toronto. She also has immediate familia in Napoli, Italia, and they will come when COVID is over.
Yeah.
Me too. Me too. I'm
Wait,
trying to come. As soon as this stupid COVID ends, we'll all be flying again. Do most children outgrow CMTC, cutis marmorata telangiectasia congenita?
Mm-hmm. Yeah. What should I say? It's basically it's a capillary malformation, and as such, it might need some form of laser treatment, but usually CMTC goes better and better with time on its own.
I believe the statistic is 70% fade out,
Maybe
30
more.
to 40% will fade significantly by age 2. Some will have some marbling or staining that'll come around with extreme temperature changes, like when they go swimming, they'll see it, or when they're very hot. But it's not like a typical capillary malformation, because they don't.
No, but technically it is.
It's a cousin. I call it a cousin. Okay, Poppy is saying our daughter is on gabapentin to prevent the pain she gets from her venous malformation. Would you recommend in changing or staying on this medication to control the pain?
May I ask where this venous malformation is and how extended it is, how extensive it is? Without knowing this, I would say gabapentin is a good drug, but there are many others that may be better for her. Basically, those drugs are the same ones that are used to treat seizures. So we have a lot of those ones, and you might want to switch from one to the other and try and see if this one is better than the previous one.
That's another study we should do someday too, is look at pain management for vascular anomalies. what's being used, first survey, find out what's being used, then we will find out on the, using the pain scale, what kind of management they get. I think that would be very interesting to look at it across the board. So Toby says her son's venous malformation is in his foot and his foot is turned inward. And how can we fix this? The radiography shows that his growth plate hasn't been affected. Any ideas?
Not really. This is more, this is a question for someone who treats vascular anomalies of the bones of the leg, and I'm not doing that. So I'm sorry, but I believe I cannot help with that.
She can ask Dr. Delphinian. He's very good at understanding the management, and he's on our website, Dr. Kami Delphinian, under our Ask the Expert.
And he's a very good friend, by the way.
Yep, he's a great guy. So Toby said Giuseppe has had 9 scleral therapies and he is now 10 years old. So I think that was the one that you had said the VM is on the foot. Oh, that's the one with the VM on the foot. So he's 10. So he's not fully done growing, but he's had 9 scleral therapies. It's interesting because, I don't know. I would like to look at imaging on that. I'm running some things through my head.
Yeah, me too, but I'm not sufficiently expert on that to give any advice.
No, but I'd like to, if she could send that to you, I'd be interested in getting hearing your
opinion. I might be able to suggest someone who I know deals with those conditions, not me though.
Okay, so Poppy is saying the one that you asked where it was located, she said from the thigh to the foot and changes all the time and continues to swell and grow. So that's the pain one. So there's another one that that's the second one that in my mind is popping fava. I don't know, maybe.
I don't know. There are some studies, I don't know if I trust them, but they say that low dose aspirin can help with these kind of pain. So why not try it?
So Holly has a good question. And again, she wants for you to discuss a little bit about the use of propranolol. What is it used for? What kind of birthmarks is it used for, and at what ages? And is it something that can be used long term?
Okay. It was some 15 years ago that by chance, Dr. Christine Lotella-Brez in France was working and helping babies with significant heart malformations. Those babies who also had hemangiomas were treated with beta blockers for their heart disease. And she was able to notice that those babies who were treated with beta blockers had their hemangiomas resolving more rapidly than those who did not were under beta blocker. So then they started to do some research on it, and they tried this on babies with hemangiomas, and they saw that it worked. So propranolol works with infantile hemangioma. It will not work with venous malformation, with lymphatic malformation, with congenital hemangiomas. It might have some role in AVMs, but this is a totally different story. So the way propranolol works in hemangioma is not fully understood. Probably it does act by inhibiting TGF-beta activation of endothelial cells, probably. To make a long story short, what propranolol does is it stops and prevents the hemangioma from exploding in the proliferative phase. And it does accelerate the involution of the hemangioma. So when to treat a baby suffering from a infantile hemangioma with propranolol, if there's an indication to do it, not every hemangioma has to be treated. Just a very small amount of those hemangiomas have to be treated. But those where you have to do treatment have to be treated as soon as possible. Because the sooner you start, the better the result. How long? This again, well, before how long, we should say how much, because the internationally accepted minimum dose is 2 milligrams per kilo a day. Some say 3 milligrams per kilo a day to be fully effective. How long? It depends. Most of the babies will need it for some 8 months to go with the baby until the end of the expected involution is finished. So not the involution, sorry, but the proliferative and steady state of the hemangioma. So 8 to 12 months. But there are some relapses after the propranolol is tapered off. So there is no rule, but the minimum I would say is 8 months. Then I want to discuss one last question about propranolol with you. And it is that there are some significant reports in the literature saying that even propranolol started late as 2 years old, can have some beneficial effect in the long run. So you should contact your doctor to discuss with him or her the opportunity to start propranolol.
And could you just add what you and I were talking about before we
I cannot say it. You can.
well, I guess what we were talking about is in different parts of the world, when they put babies on propranolol to shrink a hemangioma, they do what we call a hard stop. So they'll just say, well, it's your baby is 7 months or 9 months or 1 year, just stop it. We've seen so many rebound when they do that hard stop. So we've been talking about the need for a slow and then even a super slow taper so that you can kind of watch it while you're tapering it and then see if it starts to rebound and then maybe, you know, put the dose back up. I mean, none of this is in literature. It's just based on me, 27 years doing this and seeing probably 100 minimum new cases a week of vascular anomalies over 27 years and just saying there's a pattern here of some of these babies that are stopping the propranolol either too soon. I read in one of the protocols, it said, when the lesion has stopped growing for 2 months, but no sooner than at age 7 months, you can then start the taper. I thought that was a good idea, that if it's the baby's over 7 months and you've had 2 months of absolutely no growth, then you could, but I don't know. Yeah, like you said, who knows? So Toby, back to Toby, her son is the boy that has the pain and it's from his thigh to his foot. Just an interesting thing that she just said. She said he has several days of pain and we squeeze the leg until the lesion shrinks and the pain subsides. So I'm just curious if that's some kind of manual lymphatic compression therapy, like she said they squeeze it.
Well, most of the doctors would recommend some compressive stocking at night, especially. So it makes sense. Some of the pain is caused by the nerve fibers being compressed by a dilated venous malformation. So if you do reduce that dilation, those fibers around the venous malformation are not stretched anymore, so the pain subsides. So this is the reason why compressive stockings are almost always suggested for lower limb venous malformations.
And I've also, Dr. Mim and myself have recommended for years water therapy like swimming to stimulate circulation. Sorry. Michelle has a great question. She wants to know, for treating infants with a hemangioma, would you ever use propranolol along with laser treatment?
Why not? Absolutely, yes. Absolutely.
And Dr. Nelson and I have talked about this, that we're seeing many patients with hemangiomas have the propranolol work to shrink it, but the superficial component, the red part, is left behind. It does, and so he's, quote, cleaning it up with the laser after it's done growing or shrinking.
Yeah. Well, again, you cannot totally predict if the staining will stay there or will resolve by itself. But again, you cannot know if it will stay there. So laser is so effective. So I would recommend doing it. I do it.
Most of our experts do. Kristen Peterson Sorburn says, I'm 45 years old with a venous malformation. I've been treated by the Mayo Clinic and Hopkins for a total of 8 procedures. I've had laser, debulking, and sclerotherapy. It's still growing. Any advice for next treatment path? It's in my tongue, cheek, and lower lip. We could actually see her, in October at the clinic.
That's within my comfort zone, so I will be more than glad to help you if I can.
So Kristen, you can email him. His email is above. Emily's posted it several times. And or if you're close, I mean, we're going to be in New York City, October 8th and 9th. You can come to the free clinic. He'll be doing a ultrasound diagnostic clinic. And then also we have the free laser, but that's mainly for superficial hemangiomas and port wines. Let's see, how are we doing for time? We have 8 minutes left. Toby Perna says her son says the compressing feels good. She's waiting actually right now for sizing of the stockings. It is actually in the works right now to get the compression.
Yeah, great to hear.
And this is something we've been trying. I'm hoping, fingers crossed, next year when we're back to normal and we'll be in California for our annual VBF conference. We're actually hoping next year to get someone to come that will do measuring for compression stockings and do a little clinic on that. I've been trying for years and now we have a connection to someone. So I'm excited about that. Terika Odom says, I'm new to the understanding of infantile hemangiomas, but my 4-week-old daughter has one about 1/2 inch on her head. Her pediatrician recommended to wait until it grows 3 to 4 times its size, but they are now sending me to a dermatologist. Are there topical options rather than oral if caught early enough? And if so, are they successful?
Okay, thank you for your question. Makes sense. Unluckily, topical beta blocker will only work on the superficial component. So they will not be effective in preventing the growth of the deep component of the hemangioma. Only propranolol oral administered will be effective on that. So no, timolol, timogel, what they do is they prescribe this timogel, which is an ophthalmic gel for eye diseases, glaucoma to be precise, will not work for the deep component of the hemangioma. I'm sorry.
Poppy said that her daughter's compression stocking made her leg grow a new mass looking lump under the skin. What other options are there to prevent to swelling and growth in her leg? I mean, I just mentioned the water therapy. We recommend that, swimming. But again, this should be evaluated because I think you and I have talked about this. There are some lesions that are misdiagnosed and they put compression on them, and that's actually the worst thing for them. So this may need to be reevaluated for what it is, correct?
Agree.
So I have a question that comes up a lot. I'd like to ask you while we have you here. With lymphatic malformations of the head and neck area, so either the tongue, the jaw, the whole head and neck area, lymphatic malformations in infants and children.
Wait, I have to stop you. For reasons I don't understand, and I believe nobody does, lymphatic malformation will not affect the upper third of the face. Never, ever. I do have an idea of why this is happening, but yeah, head and neck, face and neck, I would say.
Okay, no, that's really interesting. I've never picked up on that. So you caught something before me. So what I want to know is, so many of these patients are either given sirolimus, surgery, or some type of interventional procedure or a combination. Is there a staging system or a way for these families to sort out which solution should they go with? Like, how would they know?
Okay, so yeah, there is a staging system. It is called the Dessert staging, but it is a site-based staging. It distinguishes between lesions that are upper as compared to the hyoid bone, or lower to the hyoid bone, and if they are unilateral or bilateral. But this doesn't necessarily tell you anything on how to treat them. So I would say that the three main instruments that we can rely on to treat lymphatic malformations are sclero, surgery, and medications. There is a role for laser, although to a less extent. So whenever a lymphatic malformation has a big chamber, a big cyst, then in my experience, sclero is exceptionally effective. For microcystic lymphatic malformations, sclero can be effective in the form of interstitial bleomycin injection, but usually surgery may be more effective than sclero. In most complex and difficult cases, then I usually use all three of them, especially in newborns, where I do use sirolimus, I do use sclero, I do myself this sclero, and I do perform surgery. Because I feel that even in lymphatic malformation, if you play the game earlier, you may be able to achieve better results.
So a couple questions just came in at the 11th hour, so we'll just stay a couple minutes to get them answered. So Donna says her daughter has a large hemangioma over her ear. It bleeds a lot. She's been on propranolol for 5 weeks and it helps, but she's afraid there is now one appearing at the back base of her head. She has been diagnosed with face syndrome. How dangerous are these?
Well, if they are managed with propranolol, I don't see any danger there. I would be very surprised if propranolol wasn't able to to manage those hemangiomas. If they are still an issue and they are not responding to propranolol, then you can remove them surgically very effectively and safely.
Selena has a good question. Can you use the topical and take oral at the same time of the beta blocker, the propranolol?
Yes, but it doesn't make sense. I would use the oral and the laser. This makes sense if you want to have faster results. Also, not many will tell you this, but local timolol will be absorbed to an extent that we are not able to anticipate. So I would not add a beta blocker to another beta blocker.
This is true. Gina, who spoke to us before about her VM, she wanted to know if she could take collagen for joint and arthritis issues. Are there any concerns because she has a VM? No.
No, but the one who will be doing the procedure must be an expert or at least confident in treating vascular anomalies, because when you do inject something around the venous malformation, you have to be totally sure that you are on the right site, because otherwise you will inject those substances directly into the VM, and you don't want this.
Christina says her daughter's 10 months old. She has a large segmental hemangioma, half of her face and neck. And she said she's been on propranolol since she was 3 days old, so that's good. But she says the doctor wants to take her off of it now. So what are her other options?
How old is she?
10 months.
Well, I would not be so afraid if I were her, because chances are your hemangioma was stopped, and most babies will not have a rebound after stopping treatment. So try to taper it, maybe slowly, and just in case you can rise it again if the hemangioma shows signs of wanting to come back again.
So the last question is from Samantha Stewart Laidlaw. She's 49 years old and she's been diagnosed with a hemangioma in and around her eye, which started growing a lot during the past 5 years. Why is this growing in her?
It is not an hemangioma, very simple. Hemangiomas are a tumor of the babies. So you will not have a hemangioma in the adult, especially not a growing one. You can have some fibrofatty remnants or some telangiectasias, but not a hemangioma, especially not a growing one. This is something else.
Okay, well, Dr. Coletti is available to answer any additional questions. We posted his name and his email. He's on the VBF website at birthmark.org. He will be in the US once and possibly twice for another project we're working on together in the fall, but definitely in October, if all is well, you know, and the world is able to get around, we're able to get around, right? And this too, praying. So if any of you want to see him at the VBF Super Clinic, we will be going live in the next couple weeks with registrations. It's free for the clinic evaluation. He'll also be doing a free laser clinic with myself sometime this summer, hopefully the end of June, possibly July, but hopefully the end of June. And as once again, he's available to answer your questions, look at pictures. He is our VBF Europe and VBF Italy director. And on behalf of everybody and VBF, we just thank you so much for taking the time today to answer our questions.
It is always a pleasure and an honor being here with you.
Thank you very much. And well, hope to see you soon in Italy. Stay safe.
Bye.
Bye.
Bye.